Well, I have to thank you all. I have to thank Peter especially for inviting me all the way across to your fabulous country to talk to you about something which is incredibly dear to my heart. It does seem a little odd, I know, to start in cardiology and end up dealing with contraception and nowadays increasingly perimenopause and menopause, but it's all to do with my great adoration of what happens to women throughout their lives, and especially in their hormonal worlds. Because we know, as women, that we change throughout our lives, and we live a lot of our life in our reproductive stages. But I suppose what has happened to me is I've now reached the post-reproductive era with perhaps a little wisdom, but also the feeling when I get up in the morning and look in the mirror that the Grim Reaper is perhaps looking over my shoulder. So I can look back at all those years, and I can look at my adult daughters and my growing family, and I can think long and hard about the whole business of contraception and how important it is, not just in preventing unplanned pregnancy, absolutely not just that, but in improving the quality of women's lives throughout the whole of their reproductive life. And actually, if we really introduce contraception well to women, then they understand their hormonal environment sufficiently, that they espouse the concept of considering using appropriate HRT in the later years. And I think that's going to become increasingly important. But of course we all know that modern contraceptive use varies profoundly throughout the world. And there are some areas of the world where in fact it is little used at all, and other areas where now the modern methods have taken over completely. And of course one of the things I do want to talk to you about today is the increasing use of long-acting reversible contraception and how incredibly important that is in the modern woman's world. But we are in an environment where in fact women are still not really making choice about pregnancy or not. They're not making choice really about when they become pregnant or how many times they become pregnant. And that is not just a problem of the developing world, it is a problem of the developed world. And I come from a country where I know that 40% of all pregnancies are unplanned. And I know that in Britain, about 50% of those pregnancies result in termination and 50% result in an unplanned birth. And I know an unplanned birth may become a wanted child, but it may equally become an unwanted child with a high risk of maternal morbidity, infant morbidity, less breastfeeding, a less good outcome for those mothers and those children. So this graph, I think, is really quite telling. It doesn't matter where we are, it doesn't matter where we live, we still have in red all of those pregnancies which are unintended. And we do have access, obviously, to abortion in the UK. We have free access and we have paid access. And I think one of the things that is really quite striking is that if you look at the percentage of all conceptions by age which end in termination, we tend to concentrate almost entirely on unplanned teenage pregnancy in the UK. We've had massive government campaigns, we've had massive funding put into unplanned teenage pregnancy. And yes, sure, 40% of all pregnancies in the under 20s do actually end in, let's get into the right place, do actually end in termination, and that is very tragic. And I know there are far less conceptions as women become older, but if you look in women aged 40 and over in the UK, we have a frighteningly high percentage of those pregnancies which end in termination. And these are women who very often come to see me, and they are devastated by the life choice they've had to make. Now, naively, you can consider that perhaps these terminations are for medical grounds, rather than just social grounds. But in fact, the percentage of those terminations carried out for medical reasons in the over 40s is 1%, and 99% are for social reasons. These are women who at the latter end of their reproductive life are still not making the correct contraceptive choices, still don't realise what contraception is happily available to them, might improve the quality of their life, might make their perimenopausal years better and easier to live, might cut down on their menopausal symptoms as they start to appear, might make their sleep quality better, reduce their hot flushes and night sweats, make their joint aches disappear, might make them feel better in those years. And the other thing, and we've heard this earlier in this wonderful symposium, is that in fact we recognise, of course, that women's fertility drops from their mid-30s and certainly by their late 30s. But equally, one of the things we don't focus on is that women start to become perimenopausal in their symptomatology in their late 30s and early 40s. The peak age of presentation in my perimenopause clinic is 42, with women whose quality of life is not what they would expect, women who are finding it increasingly difficult in their relationships and in their jobs, with 1 in 10 perimenopausal women in the UK having considered giving up their work because they are no longer able to cope. So we are missing the ability to say to older women that we can help them. We are not talking to them about how they might want to control their hormonal environment and their fertility and not put themselves in the position of having these unplanned pregnancies. Coming back to the young though, we actually know that the number of these unintended pregnancies which actually occur because they are using contraception but not well enough is frightening. 66%, 2/3 of the unintended pregnancies in young women result from imperfect contraceptive adherence. Now we can blame the young, we can say, oh, young women, they're not taking things properly, why don't they get their act together and actually remember what they're doing? But we could equally have a good long hard look at why a lot of these young women who cannot use daily contraception well are not in fact using long-acting reversible contraception. Why are they not using intrauterine devices and an IUC? Is it because they have declined that opportunity, or because they have no concept at all that these methods are available and available to them and will not only not cause them harm, but might actually cause them good, improve the quality of their life and keep their fertility on track for when they do want to have a pregnancy? So if you actually ask young women, and you ask us why we think there are these high rates of unintended pregnancies in young women, of course we say that it's because young women are very, very fertile. But in fact, if you look in the Western world, if you look in Europe, and you look in America, it's because of the use of oral contraceptives. Now I know, and I have a slide later, that your use of combined oral contraceptives in South Africa is far less than it is in Europe, in fact. But in Europe we have a problem because we have almost sold the pill as the method of contraception for all young women, all young couples. And yet we know that in fact a lot of young people are very poor at taking the pill, and that this poor usage results in unplanned pregnancies. But we also have a substantial proportion of young women using no form of contraception at all. And in the UK, that's about a quarter of our 20 to 24-year-olds, possibly our most fertile young women. And 1 in 5 of 25 to 29-year-olds, again, with massive fertility. And it's not because all of these young women are not in a relationship, or at least not having sex. It's because they constantly tell us that they don't feel they need to use contraception if they genuinely don't have to, and they don't currently have a boyfriend or a relationship. They stop and start their contraception, which leads us to believe that they must believe that when they're using contraception, it's doing them harm. If they believed it was doing them good, they would not stop and start all the time. So, sorry, I seem to be going backwards, not forwards. Let's get this right. Age alone should not limit contraceptive choice. Choices should be made at each life stage with clearly provided and accurate information with the goal of efficacy, convenience, and improving the quality of life. Now, I know that we're all aware, in a rather boring kind of way, especially if we're going to call this family planning options, that we classify contraceptions, and it's not exactly rocket science. We classify them according to whether they're reversible or not, whether it's sterilisation, either male or female, or whether they can reverse it at some stage, as to whether they're short or long-acting, as to whether they're hormonal or non-hormonal. But you can see from the red text in this slide what we in the contraception world now believe is fundamentally the most important choice between short-acting and long-acting. We also know that we have to distinguish between hormonal and non-hormonal methods, but that we need to explain the business of using hormones better to young women, because they are very frightened of all exogenous hormones. They're not frightened of their own hormones, rather bizarrely. They think that any hormone that you have naturally can only do you good, and any hormone that any of us as healthcare providers offer to you is bound to do you harm, rather than offer any benefit. Now, of course, we all address that, and we try to, but do we really put that across well to young women? That not only could they have better skin, better hair, but actually they might preserve their fertility. I came from an academic unit in Bristol where we studied the impact of chlamydia on young women, and we did a 2,000 women study of our under-20s with chlamydia. We had a chlamydia rate of 12% in that population. Interestingly, we discovered at the end of that 2 years that the young women who'd been on the combined pill had a shorter duration to their first pregnancy than the women in that study who had not been on the combined pill. Now, that's very interesting, and we actually looked at the possible reasons, and we were looking at the changes in immunity in young women using the combined pill, and the fact that they were being protected from the immune damage that is inflicted by recurrent doses of chlamydia. So we are not telling young women that in fact being on the pill may in fact protect their long-term fertility. There are many things we do not tell women when they make their contraceptive choice. We also, obviously, need, therefore, to focus more on short-acting versus long-acting methods. We need to understand what we understand by long-acting and what women understand by long-acting as well. For us, sometimes, if we say this lasts 5 years, it may be very off-putting. And a young woman of only 21 or 22 may actually think, well, I'm never going to get that old anyway. Why am I going to want to use something for 5 years? And we don't explain that in fact she can choose to have it removed at any stage during that time. We shouldn't be judgmental. We shouldn't bully young women who've chosen to have a longer method and try and make them keep it when their life has changed and they're no longer happy. But of the long-acting methods, you will see that I don't actually include injectables. I don't believe that something that is once every 12 weeks or 14 weeks is actually long enough. We should be considering the implants, the copper IUDs, and the levonorgestrel IUS. We actually know, and this is the graph which shows the difference between South Africa and the United Kingdom, that we are actually steadily improving the usage of long-acting reversible contraception in the United Kingdom. We now have about somewhere, it depends which study you look at, between 12 and 14% of our women of reproductive age using contraception, now using long-acting reversible methods. We are reducing dramatically the number of women who are choosing to have laparoscopic sterilisation at a young age. We have a 42% divorce rate in the UK, and we have far more people coming back asking for reversal of sterilisation than is acceptable. We also do, as you can see here, have a higher uptake of the oral pill, we have a higher uptake of IUD, and we have still a large number of men having vasectomy. We all still regard using male condoms as one of the modern contraceptive methods. I'm not so certain we should be. And this is a very busy slide, I apologise for this, but the thing I've tried to highlight here, and you will have heard all the way throughout this conference in any talk on contraception, is that we have to distinguish between the statistics that we offer to people, both when they're in medical training and when they come to us in the clinic asking how efficient methods are, and we quote perfect use statistics, and none of us are perfect users. None of us ever have been. Who of you in the audience has efficiently and reliably taken every dose and course of antibiotics that's ever been given to you? taken it on time, and finished the course with no tablets left in the end of the packet. None of us have managed to do that. We are human beings. We are non-compliant. So let's look at typical use, and you will see that if you genuinely look at the combined pill, it is not 3 in 1,000 failures per women years of use. It is 9 in 100. Whereas if you look at levonorgestrel IUS and the subdermal implant, we're not lying when we say it's 2 in 1,000. We are being accurate. And that is the kind of information we need to give to people so they can properly make informed choice. Contraceptive efficacy is the single most important reason for choosing a contraceptive method, and we know that. Yet women's perception of efficacy may be completely inaccurate. What you need to look at in this graph in red is the overestimate of how well things work. So if you look at pills, women actually think they work remarkably better than they actually do. And in green, you have the underestimate. So they do not think that IUCs work as well as they really do. Obviously, you can also see the gross overestimate of how well condoms work. But you need to be frightened by the next slide, because the next slide is not what women think, it is what we think. And here is the really, really bad news. Sorry, I'm going backwards again, I must learn this. That primary care physicians are completely and utterly wrong in their estimation of how well contraceptive methods work. And they are therefore actually giving totally inaccurate information to their clients who come. If they genuinely believe that oral contraceptives work so much better than they do, then really they should be taken back to medical school and given some basic lessons in contraception and what to offer people. They also, as well, underestimate how well intrauterine contraceptive devices work. So what we really need to do when we talk about contraception is, yes, talk about avoidance of pregnancy, talk about how easy it is to use, talk about the low instance of what I like to call negative effects rather than side effects, talk about whether a woman wants reversibility or not, but also talk to her about what she might achieve by way of add-on benefits in her life. Maybe she does not want to have a monthly cyclical bleed. Maybe some women do. Maybe some of us, if they know it is in no way harmful, would choose to have less bleeding, would choose to have less frequent bleeding, or might choose to have completely absent bleeding. And maybe they would like their contraceptive method to generally make them feel better, because then they would have the incentive to want to go on using it, irrespective of whether there's a man or a partner in their life or not. So the common myths about contraception are this. Contraception is the best of a bad lot. It will inevitably make me feel less well, and therefore I'm going to have to choose something which is the least damaging. That's not a very good starting point. There's also this terrible conception that pregnancy does not happen to me, it happens to the other woman. And of course we all know that is completely wrong. Pregnancy can happen to any single one of us. Then this myth I've alluded to, that our own hormones are all good, other hormones are all bad, the menstrual cycle and bleed is normal and good. Well, I've grown up in the Western world, where every young girl, when they start to menstruate, believes that this is what they should have every month. And in fact, when I say to young women, what is the normal female hormonal status, they're sort of blown away when they've thought about it and realise that, of course, women were designed to be pregnant, then lactating, then pregnant, then lactating, then pregnant, then lactating, and then finally their reproductive era is over. So we are actually not understanding generally that no bleeding can be good and fine. And hormonal methods make you fat and lead to problems. So our contraceptive choices are generally made by looking at what the media tell us, which is all to do with health risks and scares, listening to what other women tell us, which is generally not the good stuff, but the negative stuff, and very often is not driven by medical professionals. And as you've seen, some medical professionals may not be giving accurate information anyway, so choices are driven by misinformation and fear and anxiety. We won't yet again spend too much time on this, but we of course know that it is worldwide that women are not necessarily using oral contraceptives well. What we do need to know is that the combined pill used perfectly is 10 times more effective than the condom used perfectly. That perfect and typical failure rates are not as we think, and that worldwide the failure rate in all age groups for the combined pill is 3 in 100 users per year, and in young people under the age of 20 is probably 8 to 9 in 100 users per year. And of course, that there's a discontinuation factor as well, that up to half of new users are no longer using the combined pill within less than a year. So what should we actually do? Well, we need to make sure that if you're going to continue doing something, you're happy with it. And if 4 in 10 users of modern contraception are not satisfied with their current method because they are worried about various things, then this is a very, very poor sign. Once again, we know that if you are actually using something well, then that will reflect in the long-term failure rates, and that of course is the most important thing. So when we look at this chart, we see the difference between the perfect use and the typical use, and we see quite graphically and quite clearly that the long-acting reversible contraceptions such as implant, levonorgestrel IUS actually work as well as we believe they work. And this actually also goes with time, that over time, the longer you've used something, then we recognise that the longer a woman has been on a pill, a patch or a ring, by 3 years, then the contraceptive failure rate is going to be creeping up. And this effect, once again, quite obviously, is far less in long-acting reversible contraception. So this is one of the things that we really need to concentrate on when we talk to women. And that reflects in how much women actually go on using things. And we can see that once again the long-acting reversible contraceptive methods are better continued at a year than the shorter-acting methods. Women are only seeking to change their contraceptive method when their current method has already failed to meet their needs. And usually the most important reason for that is that they have already had an unplanned pregnancy. That surely is something that we need to actively address, so that we should be actively talking to our women and discussing and prescribing long-acting reversible methods before they have had that unplanned and unwanted pregnancy. Women are telling us that this is what they actually want, that they are embarrassed to ask us. They think that we think that they should know, and so they're not actually coming to us and saying, I don't understand and I don't know what's available, please help me. So these are the things we need to be talking about and raising awareness of. When we talk about intrauterine techniques and intrauterine devices and the IUS, 83% of the world's IUC users are actually in Asia, and almost 2/3 of the world's IUC users are in China. So this is quite extraordinary because the rest of us have a long, long way to catch up. When we look at one particular study, which looked at women who were either chosen to use the Mirena or had chosen not to use it, and looked at the differences between the two, we found that the Mirena users actually were turning to medical sources for their information. And they still, however, felt that most of the information they were getting were giving more negative than positive stories. And they still said that levonorgestrel IUS in their minds was generally about the same as a copper IUD. They didn't generally understand the difference between the two. However, those that were using the Mirena, most of them, 9 out of 10, were doing so because it had been recommended to them by their gynecologist rather than their having found out in any other way. When they asked the women who had chosen not to use Mirena or levonorgestrel IUS why they had not chosen to use it, the main concern was due to pain during insertion. And this was mainly the women who were career women, the women who had not as yet had a child or become pregnant, and they viewed insertion with considerable apprehension. They were afraid of pain, they were afraid that it would damage their womb. And the solution appears to be that they need to see how the procedure is performed. They need to touch, hold and feel an IUC, to have one in their hand, to be told about the possibility of pain relief, to be told that the person performing the insertion is competent. And we know that's particularly important for young women before they've had children. There's another concern about cost, but of course we know from all the cost-efficacy studies, the cost-effective studies, that in fact even at a year of use, using an IUD or an IUS is more cost-effective than having used the pill. There's a concern also about absence of bleeding. And women who'd completed their families seem to be particularly worried about the fact that a levonorgestrel IUS might get rid of, or at least almost get rid of, their periods, because they felt it was pushing them into early menopause. So yet again, if you explain that it's not affecting their ovarian function, this is purely to do with their womb lining not bleeding as a response to their own ovaries, they start to feel much better, and they start to view it as a positive effect rather than a negative one. And again, that must be us that explains it to them. This was an interesting study performed in Austria, which showed that of women without any menstruation-related symptoms, these were not women who had dysmenorrhea and painful periods or heavy periods, actually more than 50% of them would like to lessen the frequency of their periods, and 50% of them would actually prefer to have no periods at all. We used to, when Morena first came in, seem to reserve it for those women with heavy menstrual bleeding or with painful bleeding. Why? Why is it not being offered to all women? Because that bleeding pattern of less bleeding and lighter bleeding and less painful bleeding and maybe absent bleeding is a positive effect on the quality of women's lives if that is what they choose. And the satisfaction is very high amongst current IUS users, and in fact, interestingly, extremely high, obviously, amongst users of their second levonorgestrel IUS. These are very, very happy, satisfied users. And be under no illusion, these are even amongst women who have not as yet had children or pregnancy. There is still this major fear of using intrauterine techniques in young women before childbirth, and we have to get rid of that from our hearts and minds, because in fact these young women, nearly 700, were satisfied or very satisfied, would recommend it to a friend, and would themselves have another fitted. So very briefly, we need to look at what our misperceptions are about pelvic inflammatory disease, infertility and ectopic pregnancy. There are many healthcare providers out there who still believe that having an IUC in situ is associated with ongoing risk of pelvic inflammatory disease and resultant infertility. I hope all of you out there are aware that this is a risk only in the first 20 days after insertion, and is a risk due to a silent STI sitting there at the cervix. It is a risk which is entirely down to us, because we are the ones that cause, if you like, that pelvic inflammatory disease and that resultant potential infertility by carrying out an insertion when we have not swabbed and treated for mainly chlamydia but also gonorrhea. There is also the perception that a woman who becomes pregnant with an IUC in situ has an increased risk of ectopic pregnancy, and in fact the whole business of this is that yes, if a woman does become pregnant with an IUC, the chances that that pregnancy is ectopic are much higher, but the chances of her becoming pregnant overall are so tiny that overall a woman with an IUC has an incredibly small risk of ectopic pregnancy, and IUS can certainly be used in women after ectopic pregnancy. We know that women before childbirth are worried about pain and various problems to do with insertion, but equally there are myths out there amongst healthcare providers that it is more difficult and going to cause more problems for women inserting in young women before childbirth, and these are completely erroneous, because in fact we know from all the studies that this is not the case. This was a study in the States which showed that when you offer really good choice and standard counselling about contraception to women, they will choose long-acting reversible methods over the short-acting ones. So our take-home message has got to be that we have to remember that the media is the first information source for many women, and that we need to raise awareness of contraceptive need. We have to be the ones to give the balanced information about the choices. We have to be the ones to introduce the new methods, because that's not going to come from the media. Only the negative stories are going to come generally from the media. We have to be aware what women are frightened of, so we can actively address those fears and allay them and dispel the myths. We are incredibly important as reliable sources of advice. We need to offer choice at all life stages. Never assume that women know things, that by advancing years they have in some way picked up information about the best choices for them. We have to make all women at all stages of life, and we have to make all of our colleagues aware of the long-acting reversible contraception. We have to be able to counsel adequately and allay women's concerns and dispel myths and motivate women to make their contraceptive choices great throughout the whole of their reproductive life, so that they can lead lives with good quality that they themselves have chosen. Thank you all very much indeed.